Good morning, good afternoon, and welcome Dr. Varsha to our chat show on high-risk pregnancy. And today we are going to discuss obstetric cholestasis or intrahepatic cholestasis of pregnancy. This is one of the most common pregnancy-specific liver disorders, and where there is derangement of lot of things, which she will tell us about. So, Dr. Varsha, what is this obstetric cholestasis or intrahepatic cholestasis? What does it mean?
Good afternoon, Nupur. Yes, obstetric cholestasis is, although not so common, but it is a very common liver disorder, which we all see in our day-to-day antenatal practice. Basically, the incidence of obstetric cholestasis is around 1.2 to 1.5% in all antenatal females. And what happens in obstetric cholestasis is there is deranged liver enzymes. The liver enzymes are elevated, the bile acids are elevated, and the patients usually present to us with the symptoms of generalized itching all over the body. More or less, the itching is limited to the palms and soles, the peripheral area, but that is the most common presentation. And this deranged liver enzymes is associated with increased morbidity and mortality, both for mother as well as fetus. That is why this disease is of significance, clinical significance to us.
So yes, we see it quite often amongst Indian women, Asian women, and their incidence is much higher than UK and US. So Dr. Varsha, why does obstetric cholestasis occur in pregnancy? What is the specific reason for it?
The obstetric cholestasis in pregnancy is related to the hormonal changes which occur in a female's body due to the pregnant status. There is an increase in the estrogen hormone which causes the stagnation of the bile. It reduces the mobility of the bile from the gallbladder to the intestine. And due to that stagnation, there is increase in the liver enzymes, there is increase in the bile acids, which is responsible for the signs and symptoms of obstetric cholestasis.
Okay. So the main culprit is bile acid. And this is the one which will go to the skin and produce itching, as you mentioned, most commonly in palm and sole. But yes, if it is very severe, it can affect different parts of the body. Maybe back, maybe your arms, your legs, your chest, and many other places. So other than itching, what any other symptom can they present with?
There is increased liver enzymes, there's stagnation of the bile flow. So it can present like a jaundice. The patients, if you ask them about the signs and symptoms in detail, most distressing symptom obviously is the itching, which can cause sleep deprivation, anxiety. I mean, it is very disturbing itching to the patients. So much of scratching is there. And other than that, they may have jaundice. They will have pale stools, dark colored urine. So it would be features of jaundice which can be there in the females.
Yes. Then sometimes even loss of appetite, malaise.
Yes, decreased appetite, anxiety related to the symptoms. And usually the presentation is in the third trimester. It starts after 28 weeks in most of the females, but it can start early also.
Okay. So mostly, yes, in late trimester, when estrogen levels are also higher. But you mentioned that this affects the baby as well. So what changes it will cause to the baby?
The most important thing which actually bothers us is the changes which occur in the baby. It can cause growth restriction of the baby. The changes which happen in the baby, it can cause sudden fetal death, sudden demise of the baby in utero, without any. I mean, it's very difficult to predict that which baby will be suffering the most. It is a cause of significant fetal distress. Meconium stained liquor. Meconium is when the babies, they pass stools in utero because of fetal distress. And the most we are worried about the sudden fetal death, which can happen anytime after 37 weeks. That is why we decide to terminate the pregnancies before 37 weeks. So another complication which the babies will face is preterm, prematurity. Prematurity, which is both iatrogenic and spontaneous. Iatrogenic is induced by us. I mean, we deliver the patient early because we are afraid of the complications which can happen after 37 weeks. And there is more chances of baby going into an ICU. And it's very difficult to predict these signs and symptoms in the baby. It's very difficult to diagnose which baby will be complicated by routine ultrasounds and the routine electronic fetal monitoring, the CTGs which we do. We are not able to pick up that which baby will be affected. So what is left with us is to monitor the pregnancy very closely. If we have diagnosed a patient with obstetric cholestasis, and do routine ultrasounds, weekly checks. Sometimes it can be twice weekly checkup also, depending upon the level of the hormones, and take the decision accordingly. But anyways, we don't allow the pregnancy to go beyond 37 weeks in such cases.
So thank you, Dr. Varsha. Yes, we know that morbidity for fetus is higher. And we have seen that when bile acids are more than 100, there is 10% risk of mortality. It is so high. So higher is bile acid, higher are the chances of prematurity, higher chances of meconium aspiration and poor prognosis for the baby. So dictum is world over. We believe that 37 weeks is the cutoff. But yes, when bile acids are more than 100 nanomoles, we sometimes also deliver at 35 weeks, maybe at 36 weeks. So we need to individualize every patient that what is the best outcome that we can offer. So other than doing routine LFTs and bile acid levels, what other tests do you recommend when obstetric cholestasis?
Okay, so the most common, whenever a patient comes to us in her third trimester or even in early trimesters with the symptoms of severe itching which is more limited to the peripheries, the palm and the sole, we try to rule out other reasons for that itching. Other reasons could be the skin problems. There are many skin related problems which are common in pregnancy, again due to this elevated estrogen hormone levels. Patients may have eczema. So there should not be any rash associated with that pruritus. And then we have to rule out other disorders in which the liver enzymes are elevated. So it is always a diagnosis of exclusion. We need to rule out pregnancy-related preeclampsia, hypertension, which will also cause elevated liver enzymes, which can be a very serious condition. There is another serious condition called acute fatty liver of pregnancy. So besides the liver function analysis, we need to do other investigations like the renal function test for the patient, a complete blood count to check for her platelet counts, to rule out all these other disorders, which can be again very serious for her. Then there are some liver related diseases also in which the liver enzymes can be elevated. It can be liver infections like hepatitis A, B, C. It can be related to some antibodies which cause these elevated liver enzymes and damage to the liver as well as to the biliary structures like primary biliary cirrhosis or elevated autoimmune diseases for the liver. So we need to do some antibody analysis also, antibody tests also, and an ultrasound of the liver and a whole abdomen scan is very important in such patients. So basically it is a diagnosis of exclusion. Once you have excluded all these things, then we label it as obstetric cholestasis. The liver enzymes, SGOT-PT is raised, bile acid levels are raised. Even if it is not raised and the patient continues to have itching, we repeat these liver function tests every 1 to 2 weeks in such patients because maybe later on it comes elevated. Yes. So these are the basic evaluation which should be done for all the females, other than the tests for babies' well-being. That includes the ultrasound, the Doppler, the growth scans, all these things for the baby.
So we know now how to monitor baby, how to monitor mother. For mother, it is basically symptomatic relief, but everything we are working around is to have good prognosis for the baby. So once we have made a diagnosis of exclusion that yes, it is obstetric cholestasis, what is the treatment that we can offer to mother?
First thing, we have made the diagnosis of obstetric cholestasis. We have to make the parents understand the significance of this problem. There are some treatments which will help them in the symptomatic relief. They can use some moisturizers, emollients, which will help in the relief of pruritus. They can use some antihistaminics, which will also relieve the symptoms of itching, the distressing symptoms of pruritus. There is another medicine called ursodeoxycholic acid, which reduces the bile acid levels, and that will also help them in the symptoms and might decrease the liver enzyme levels, also can bring them back to normal. I've seen patients who have bile acid levels of 56 to 30, 50 to 60, and it comes back to absolutely normal after starting this medicine. But what we have to make them understand is that symptomatic relief and even normalization of the liver enzymes does not mean that the baby is not at risk. Anyone who has been labeled as obstetric cholestasis, the baby is at risk. We need to deliver them by 37 weeks. We need to closely monitor this pregnancy and take all the necessary precautions. There is a possibility of preterm delivery, prematurity, baby going into an ICU, patient having jaundice, patient having excessive bleeding after delivery. There is increased possibility of delivering by a cesarean section. Although normal delivery is not contraindicated, we all give 100% trial for a normal delivery to all our patients. But still, for an induced labor, there's always a possibility that it can fail sometimes and you end up having a cesarean delivery.
So yes, and now we have seen that the main culprit is bile acid. And if bile acids are high, we need to be more vigilant. Our counseling has to be perfect. And almost 20% of women with cholestasis still will have normal OTPP or normal LFPs. So the main thing is bile acid, and that is what we also focus on. So Dr. Varsha, once the delivery has happened, we know that delivery is also high risk in such women because there are more chances of blood loss, and we sometimes also give vitamin K to improve clotting in such cases. So once now the delivery has happened, how do we follow up these women?
Yes, Dr. Nupur, definitely these patients, they are at high risk of having excessive blood loss after delivery, postpartum hemorrhage. So that part has to be taken care of. Vitamin K is a very important medicine. If we see anyone having, along with the abnormal liver function test, along with abnormal liver enzymes, if they have elevated coagulation profile, prothrombin time is raised, then vitamin K can be given even in the antenatal period. Once delivered, this itching and the liver enzymes come back to normal. That is basically a diagnostic criteria for obstetric cholestasis. If it is obstetric cholestasis means the elevated liver enzymes which are related only with pregnancy. So it will come back to normal, and that test has to be repeated after 10 days of delivery. Other thing which we have to keep into consideration, and we have to inform the patients and her husband, that there is always a possibility of recurrence of obstetric cholestasis in consecutive pregnancies, and that risk goes to as high as 90%. So they have to keep that in consideration in their next consecutive pregnancies as well.
So thank you, Dr. Varsha, for elaborating this condition in so much detail. And we see this quite commonly in our clinical practice. This will not only benefit the people who are going through this during their pregnancy, but also clinicians who are working at periphery, who know that how this pregnancy has to be monitored very carefully, and how counseling will play an important role, and early diagnosis can improve prognosis. Although we know that correcting liver enzyme and correcting the bile acid will not much change the prognosis for baby, but yes, intensive monitoring will help us in early delivery and timely diagnosis, and shift to nursery if required after delivery for the baby.
Sure. they can actually take into consideration this thing because yes, the baby might need an NICU. So if you don't have an NICU facility, you should as well transfer these patients to a higher center if you diagnose it at an early stage, the problem.
Thank you so much.
Thank you so much, Dr. Nupur. Thanks a lot.